Good evening. Good evening. Glad to see you came out and suffered through the cold weather. Somebody texted me earlier today, said, "We're going to cancel tonight." It's just cold. It's just cold. Duh. When I grew up, yeah, yeah. You know where that goes, right? When I grew up, yeah, uphill both ways, no shoes. Yeah. See, you guys have heard it all. Anyway, I appreciate you being here. We're going to get started here. A lot of ground to cover. Not as much time to get it covered. Bobby Grizzle had surgery yesterday. All went well. Dennis Hogsett had a procedure. Sorry, Dennis Frazier. Didn't mean to scare you. Hogsett had a procedure on Monday. All went well. Leah Cecil has been in the hospital, but she went home today. And those are the ones I know about. Prayer requests. Donna Elshire. Okay. Your other brother, Larry. Oh. Speaking of Larry, remember Larry Medcalf? He went home Sunday, but still needs to recover. Still needs some healing. Jeannie. Okay. Yep. Mm. Yeah. Yeah. Let's remember that. Somebody else had a hand up. Angela. Okay. Your dad. Your brother-in-law. Hmm. Remember everybody in Angela's life. Everybody. Suzanne. Hmm. Okay. Let's remember those. Hang on, Dave. I don't care what's going on over here. I'm trying to hear Dave. Right. Good. Continue to remember Kevin and thank you for Connie. Josh. Oh boy. Well, let's remember Connie Smith. Gary. Melissa's hip. Gary's requesting prayer for Melissa's hip. All right, let's stand. Let's stand. Don't let me pray by myself. Let's all pray together. Lord, thank you for today. Thank you for your awesomeness. Thank you that you are a God in heaven that loves us, cares about us, a God in heaven that is our protector and our provider, our healer and our deliverer. Everything that we need for you to be, you are. And for that, we're thankful. We're thankful that we can call on you in any circumstance, knowing that you're the God that's able to do that which is far more than we could ever ask or even think of you to do. So we just ask you to touch these needs. God, everyone that's been mentioned, those that are represented by someone that's here tonight or on our prayer list, whatever the need might be, we know that you are able. And so we just present these needs to you and ask you, Lord God, to let us hear reports of victory and testimonies, how you've touched your people. God, I continually pray for our church, that you would just continue to help us, lead us, guide us, and direct us into the path of that you've laid before us, that we might be the church that you need us to be. I pray for every classroom, God, that lives will be touched by the good news of Jesus Christ. God, I pray that you would just help us tonight in this classroom as we continue our journey. Pray for Crystal, Lord God, that you'd just let her have clear thoughts and clarity of speech that we might be able to hear from her tonight. So in all that we do, Lord God, we want to bring praise, honor, and glory to you, for it is in Christ's name that we pray. Somebody say amen. Amen. Turn around to 3 or 4 people, shake their hand, hug their neck, bump their knuckle, tweak their cheeks, bump their rump, do something. Do something to let them know you're glad to see them in church. Man, it's hot in here. It must be a warming center. I just want to take just a few minutes before I turn it over to Crystal. Just please remember that I'll have this other microphone. If you have comments, questions, while she's teaching tonight, please just lift your hand. Let me get to you with the microphone since we are recording this. But I just want to say how much I've enjoyed the last 4 weeks. I mean, I know it sounds crazy to say you enjoyed talking about death, but I just appreciate the opportunity to share with people about a very important issue, and not just here, but I've heard back from a lot of people that have been watching online. They can't watch it live, but they can watch it, tomorrow, and even a family that may be here on Sunday that's going to come as a result of us talking about death and dying. So I think it's really cool. I've enjoyed it. I hope that you've enjoyed it as much as I have. I appreciate the participation, the talking back and forth. I'll be honest enough to say I've not heard Crystal actually teach, but I'm going to assume that she would welcome that as well. Any kind of question. I love that. If you weren't here during the first session, let me just quickly tell you who Crystal Vance is. She's a palliative care nurse practitioner. Don't forget the practitioner part, because if you do, you'll get reminded. Not by her, but by her husband. And he said he's got the student loan money or bills to prove it. She currently is at Cabell Huntington Hospital. In 2005, she graduated from Marshall with a Bachelor in Science of Nursing. After graduating, Crystal worked at the Acute Care Oncology Unit in Ashland, Kentucky, where end-of-life care became a passion to her. After 6 years of bedside nursing, Crystal began working on palliative medicine as a consult service. And then wanting to further education, she returned to Marshall and in 2012 obtained a master's degree in nursing as a family nurse practitioner. Since that time, worked at outpatient oncology clinic and more recently at Cabell Huntington as inpatient palliative care nurse practitioner. And then in 2017, she received certification in hospice and palliative care advanced practice nursing. So someone I feel, that I've known for 15 years, but also very qualified to help us as we continue this journey talking about death and dying. So before I turn it over to her, let me just say that I hope that you have got what we've been trying to say the last 4 weeks, that, we die because sin entered the world, that when we die, it's absent from the body, present with the Lord, that really, if we learn to live well, we can learn to die well. And in doing the living well, it's becoming more like Christ. That's really the 4 weeks of what we spent. And rather than me try to wrap that up, I saw an illustration recently, and maybe you've seen it. Francis Chan He does an illustration I think wraps up what I've been trying to talk about the first 4 weeks. So before I turn it over to Crystal, let's watch this illustration. Oh, wait a minute. Before we watch the illustration, I got this from somebody this week. Die and they'll come from miles away to see your body. Live and no one will ever come by unless they need you. Isn't that the truth? Watch this video.
There's a lot of things I like here in Simi Valley. There's a lot of things I like in Southern California. There's a lot of things about this home that I'm building for myself that I want to look back on. Do I want to give that up? Do I want to give that up? Well, that looks kind of appealing. Paul goes, man, I can't do that. And I've got to keep looking forward. Because the moment I look back, I'm going to lose this race. Because I'm like a runner. All I think about is that finish line. All I think about is, man, one moment I'm going to see Jesus, and I'm going to spend my life preparing for that moment. I want to cross that line. I want to get my reward. It's all about that. He goes, I don't look behind me. I look forward. I forget. The one thing I do, I forget what's behind me, and I'm just looking to the end. I mean, how many of us really think that way? How many of us live that way? Looking to the end. You know what's interesting to me? This whole thing about forgetting what's behind and pressing on toward what's ahead. What does every counselor tell you to do? Look back. Let's go back to your past. What happened a few years ago? Oh, yeah? Well, then what happened when you were an adolescent? Let's talk about your early childhood. What happened there? Maybe some things in the womb. What happens? Was there distress? Did your mom have any? We're always going back, looking back, and Paul says, one thing I do, I forget what's back there, and I look forward. Is it true that there are certain things I do because of my past? Yeah. But there's a lot more that I do because of my future. You know, I do things, and we gotta focus on this, you guys. The world's going to keep making you look at your past, and we got to keep looking at the future. You look at your past, you're going to get depressed, and you're going to get stuck in your past. You look to your future and go, man, what is that moment going to be like? See, my actions, a lot of the things I do is because I'm thinking about my future, and I'm thinking about that moment when I see Jesus, because I realize that everything I do is going to bring either reward or regret. It really is. I've got an extra $1,000. Okay, on that day, that future, when I see Jesus, what is going to bring reward and what's going to bring regret? I could buy a lot of fun things for myself with that $1,000, but on that day, Paul's saying, I'm just looking at that day, going on that day, maybe I just give it to the poor, because on that day, I'll be rewarded for it, versus, yeah, I mean, we've all bought things we regret, right? You go, oh, that was a waste of money, that's a waste of money, that's a waste of money. Think about what we're going to say at the end when we stand before God. Are you going to regret the car you drove, regret the house you lived in, regret the clothes you wore, regret, just everything? What are you going to regret? How about your time and how you spent it? Are you going to go, oh, I'm so glad I watched 7,000 movies? Or are you going to regret, wow, I wasted all of that time down? It's about the future. Paul's going, man, what am I to look forward to at the end? I'm going to bring an illustration that, this is like the first illustration I did. It was 20 years ago, but I can't think of a better way to explain it. I actually didn't use a rope back then. I used remember computer paper when it was all stuck together and it had the holes on the side that you had to peel off? Remember that? I remember getting a roll, and some of you guys have no idea what I'm talking about, which is crazy to me. But because that was the best, and it never worked right because of the rolling things. But I remember being a youth pastor, and I put that computer paper all the way around the room, and but I'm going to use a rope now because I can't find that computer paper. Imagine this rope, okay? Pretend this rope just goes on forever, okay? Just imagination. Pretend it goes around the world a few times. It doesn't. It ends at the rock. But let's just imagine this thing goes on forever. Now imagine that this rope is a timeline of your existence. You just exist forever. You see this red part? This would represent your time on earth. You've got a few short years here on earth, and then you've got all of eternity somewhere else. This is your existence. And what blows me away is some of you, all you think about is this red part. It's all you think about. You're consumed with this. You go, oh man, I can't wait till here. You know, I'm going to work hard. I'm going to save so I can really enjoy this part right here. And you're consumed with that. And you're thinking, oh man, am I going to get to travel? Am I going to eat well? Am I going to do this during this part? And I'm like, are you kidding me? What about this? What about this? What about all this stuff? It's crazy to me because the Bible teaches that what I do during this little red part determines how I'm going to exist for millions and millions and millions of years forever. And so why would I spend this little red part trying to make myself as comfortable as possible, enjoying myself as much as I can? Paul says, look, I'm going to live my life for this mission. I'm going to spend my life, invest my life for this moment when I cross that finish line. See, I'm going to forget about all this stuff I could enjoy, and I'm not going to look around. I'm going to be like a runner just looking at that moment when I face God, because when I face Him, then I don't get this chance over again. We get one chance at this life on earth, and it can end at any second for any of us. We've got one chance at this, and then comes eternity. And I'm not going to be fooled. I'm not going to spend my life down here. See, people look at some of my decisions and go, oh, you're so stupid because that's going to really affect this. I go, no, you're stupid because it's going to affect all of this. Man, I'm serious. I look at the way people live and I go, wow, that is so crazy. You are so crazy. You're going to do that right now, just to enjoy right now, not even knowing if you have tomorrow, and you think that's smart and that I'm dumb? It doesn't make any sense. Paul goes, I'm not going to look around at all this stuff. And it's tempting. It's tempting to all of us. That's what I'm saying. Down here, it's crazy because everyone lives that way. Everyone lives for the red part. No one's thinking about the millions of years afterwards. It's just this crazy deception that we can't get out of our minds. And Paul goes, I'm not doing that. He goes, I keep my eyes on that. I keep my eyes on that finish line, and I'm going to forget what's behind me. I'm not looking around. I'm straining, because I'm straining forward. I'm like stretching forward for that mark. I'm going to pass this thing. I'm going to live this out, and I'm going to face Him. I'm going to come before the judges, and He's going to hand me that trophy. He goes, I'm going to get it. And I haven't gotten there yet. He goes, but you better believe I'm using every muscle, exerting every bit about me, because I'm going to pass that line well.
So I think that's what we should focus on, is getting to the finish line and being more like Jesus than we can imagine that we could be, and to work hard to do that. So Crystal, come and take over. Get this microphone out of my hand.
Do I have to do anything? Do I have to? Okay. Hi. I'm so used to talking to like medical professionals. So if I say medically stuff, just stop me, okay? Because if you don't understand what I'm talking about, somebody else probably doesn't either. So just a little bit about me. First of all, I feel like I should tell you that I've worked in healthcare for about 15 years now, and it's given me a really odd sense of humor. So if I say something trying to be funny, it's just the way I cope with things. Don't take it offensively, okay? And the other thing is I am very passionate about what I do, almost to a fault. I'm a huge patient advocate. If a patient tells me this is what they want, I will do everything in my power to do that. And sometimes that gets me in trouble, but that's okay. And, you know, the other thing is that a lot of things that I talk about is not popular. No one likes to talk about it. A lot of times when I go in a room and, you know, I say, hey, let's talk about your imminent death. Doesn't go over well sometimes. But that's okay because, again, I'm a huge patient advocate, and my goal is to make people die as happy and as comfortable as they possibly can. So I'm just going to show you a little video. It's not as inspiring as the one previously shown. But this is just a little bit about what I do. I don't just see people who are dying. You know, I also see people who are chronically ill. So patients that have congestive heart failure, end-stage lung disease, those sorts of things. So don't think I'm just seeing, end of life patients. So this little video just shows kind of what palliative care is.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic. Traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
So that's pretty much my job in a nutshell. I'm a good supportive person. Okay, so first I'm just going to talk a little bit about trajectories of diseases, right? So I know all of us, we've talked about this, a lot of us pray for what at the end of life? We just want to go quick, right? Even though I really don't think people mean that when they say that. But that's kind of what we all pray for. But that's not usually the case. Usually people are diagnosed with some sort of chronic illness, and they go on kind of this stair step, right? So you're kind of going along, you're diagnosed with a chronic disease, you kind of fall a little bit, and then you'll level back out for a little while. Then you have another little acute episode, and it kind of starts this stair step disease. That's typical of most people who have chronic heart disease, lung disease. Cancer looks a little bit different than that, but for the most part, this is what most people's lives kind of look like. So my job is to talk to you way back here at the beginning of your disease, not at the very end of the disease. So this is something you're going to hear me say a lot, okay? There's a big difference in quality of life and quantity of life. We can keep people alive for a really long time. I mean, a really long time. You may not know what planet you're on, and you may be in a bed getting artificially fed, but you're alive, right? Which is a lot different than your quality of life. And the thing about quality of life is my quality of life probably looks different than your quality of life. So the person that gets to determine your quality of life is you. Interestingly enough, I read a study not too long ago, and I think maybe PT mentioned it. The number one thing that people say is worse than death. Any ideas? If people say, I don't want to live if I can't walk, what's some other good ones? What? Drive? Eat. That would be mine. Shop. Yeah. It's actually if I can't go to the bathroom on my own. If someone has to clean me up, that's the number one answer. Wasn't pain. If I'm miserable in pain, that wasn't the number one answer. Walk. Interestingly, it was if I can't go to the bathroom by myself, then I don't want to live, right? So what is the most important thing to you? And this is, I think, if you're going to have a conversation with your family, this is the answer that you need to come to. If I'm talking to my loved one about what their wishes are, I want to know what's most important to you. if I tell you you have a life-limiting disease, how do you want to spend that time? Where do you want to be? What do you want to be doing? Who do you want to spend that time with? Most people, oddly enough, usually want to see their grandkids, not their kids, their grandkids, or their dog. That's almost always the answer. Just want to see my dog. And again, what do you determine as quality of life? I have some patients who, as long as they can blink, as long as they can sit in a chair and watch TV the majority of the day, then that's fine. I had one lady who all she needed was a colostomy. That's it. She completely refused, and she ended up passing away because of that. But that's her quality of life. She didn't want to live with that. So that's almost, usually when I meet a patient for the first time, that's usually my first question. Tell me how you determine, a good quality of life. If I can interact with my family, if I can eat cheesecake, again, that's mine. But you get to decide that. So this is just another question that I usually ask. I have a tendency to talk to patients about how long I think their life expectancy is, if they want to know. Some people tell me they don't want to know. But the number one answer to that question is usually what? When we hear somebody's really sick, what's the number one kind of, hey, this person has this long to live? It's usually 6 months, right? For whatever reason, that's the magic kind of number. And there's lots, we'll talk a little bit more about that in a second, but there's lots of signs that people are dying. You just have to be looking for those signs. People who aren't moving around a whole lot, if grandma's sitting in a chair 16 hours a day, not eating good is another sign. Talking about dying is a really big one. So there's signs that we can see that, people are kind of at that end of life. But this is one of my favorite questions that I get to ask people is, if I told you you had a month to live, what would you want to do? You know what I almost never hear? Be in the hospital. Yeah, I'd love to be here eating this, terrible food, being poked and prodded and having a bunch of tests that isn't going to change my outcome. That's almost never the answer, right? So that's actually my favorite question to ask. And I maybe should have asked, but I'm looking around, and I feel like I've interacted with a lot of your families, actually, on this topic. I don't know if any of you know Kim Workman and Christy Douglas, but I got to meet Christy Douglas kind of in her disease process. I hope they wouldn't mind if I talked about this, but Christy had cancer and had lived a rough life, I think it's fair to say. But I tell you what, when she looked at me and said, I'm going to die, aren't I? And I said, yeah, you are, probably soon. She turned into a completely different person. And it was one of the most beautiful things I've ever, it was like she was free. And she just completely turned her life around, and all she wanted to do was go to the beach. That was the goal, right? And I hear that a lot from people. I just want to make it to a graduation or make it to a wedding or see my grandchild born or something like that. So, there's no CAT scan that's going to give you that, right? That's a conversation that we have, and we say, this is our goal, and we're going to work toward this. We've planned fake graduations. We've baptized people in the whirlpool on the burn unit. We've done weddings. That's what's important to people. It's not, none of the other stuff matters. It's all about that one goal that people want to get to. Okay, so here's I kind of jotted down just like the big decisions that people talk about. This is a big one, CPR and life support. This is probably one of the hardest things that people have to kind of figure out if they want or don't want. And here's what happens. Let me just say, I love doctors. I work with some really great doctors. They are not great at having this conversation because typically what happens is they'll come in your room when you're short of breath, and you're gasping for air, and they'll say, "If you die, do you want us to let you die or do everything we can to bring you back?" And that's the end of the conversation, right? Well, first of all, that conversation should never happen when you're gasping for air. Because even if I hand you a life jacket and it's full of holes and you know you're going to drown anyway, you're still going to put the life jacket on, right? That's like one of my biggest pet peeves, is the whole do nothing approach. So this conversation should happen long before we get to the point of, okay, you need it right now, okay? So we'll just talk a little bit about CPR, and I'll answer a couple of questions that I got on the first week. So basically what CPR and life support means is if your heart stops or you stop breathing, okay, do you want a team of people to come in, do chest compressions, and put you on a life support machine? Now, that does not mean that we won't do everything we can up until that point, but if it gets to that point, your options are chest compressions, life support machine, or natural death. Okay? Now, this is different, if you're in a car wreck or something like that, something very acute happens, that's one thing. But if you've been doing this, right, that whole stair step of your disease process, then this is a conversation that we really need to have. And the other thing is, if we do end up doing all of these things, how long do you want to be left on that machine? So one of the questions I got was, if you're brain dead, I think is what it said. If you're pronounced brain dead, is it okay to unhook you? Is that what it said, pretty much? Are you spiritually dead? Okay. So here's the answer to that question, because we get this question a lot. If you are actually declared brain dead, meaning there is no flow to your brain, it is illegal for us to keep you on a life support machine. Okay? It's not an option. You can't keep someone hooked up who is brain dead. So yes, you are clinically dead at that point. The problem, and before, I won't go into too much science, but what controls your breathing and the involuntary things that your body does is way back here, and that's almost never affected when you're brain dead, right? So this can still be working, but all this is not, right? So if you are actually declared brain dead, we have to unhook you. I think it's 48 hours we have to unhook you. So it's not an option at that point. Nobody has to decide anything, or we decide that for you. Question? Yeah.
Is that something recent that has come up?
No, that's been the case since I've worked in healthcare. If you're declared actually brain dead, now you can be in a vegetative state, meaning you've still got brain flow, but you can't talk, you can't speak, you can't eat, you can't do any of those things. But if you are actually declared brain dead, and the way they do that is they do a flow test to see if you're getting any flow to your brain, and they do a bunch of other weird tests. They squirt cold water in your ear and touch your eyeballs and all these weird things. But if you're declared brain dead, we cannot keep you hooked up to a life support machine. That's the law.
Okay.
Yeah.
I just
Well, but the problem is that most people aren't declared brain dead. They're just declared in a vegetative state, meaning, they can't talk, move. Right. They're not doing anything purposeful, but they still have brain flow.
But they respond to pain stimuli?
Sometimes no. Your brain is there's areas of your brain that can control certain things. And so even someone who is in a vegetative state can still respond to pain. They can still cough. They can still gag. They'll still do those things. But that's not the same as being brain dead. Being brain dead means there is no flow in your brain. None. Zero. And that's when we talk about things like organ donation, which was another question. Do you remember what it said? Yeah. So organ donation, they will come to you and talk to you about things when someone is declared brain dead. So if you're declared brain dead, then the organ harvest team will come and talk to your family about donating your organs, because and they'll keep you alive until that process is complete. Does that make sense? No, not so much. Yeah. It's actually easier, and this is going to sound bad, but when someone's declared brain dead, that makes it easier for the family because they don't have to decide anything at that point. It's when we're in that gray area that makes it very, very difficult for families to make decisions. Okay, so here's the biggest question. Can the underlying issue be resolved? Right? So if I have terminal cancer, and I'm a cancer nurse, so I talk about cancer a lot. If I have terminal cancer, is it beneficial to put me on a life support machine? Because you can't fix that underlying issue, right? So that's the things you have to think about when you're talking about putting someone, on life support and doing CPR and that sort of thing is, can I fix the problem that got them there in the first place? And then again, what quality of life am I bringing that patient back to? Right? So if I put someone on a life support machine or I do CPR, did I improve their quality of life? Am I able to make them feel better? Are they going to be able to go to the bathroom? Are they going to be able to walk? Or whatever it was that they defined as good quality of life. Is this too much? It's a lot of medical stuff. Okay, so this is my favorite quote. End-of-life decisions should not be made at the end of life. Again, if you're in a situation where you're in a lot of pain or you're very short of breath or you're having a lot of other physical issues, that's not the time to talk about this stuff, okay? This should be done way back at the beginning when you're able to make that decision. Okay, so to treat or not to treat. So first of all, let me just say, I've been a nurse for 15 years. I've given people chemo. I've given people lots of life-saving drugs. I love medicine. It's what I do, right? But I also am a big advocate for not doing those things if it's going to be harmful, cause more harm than good for that patient, right? So, medicine is ever evolving. There's a ton of new treatments out. I'm sure you guys have all seen these immunotherapy commercials. My favorite one's the Opdivo one where it says something like, and who wouldn't want to live longer? And it just it makes me cringe every time I see it. But there's always going to be another test. There's always going to be another drug, right? There's always going to be more and more and more things that we can do to people. But what you kind of have to decide is, again, how's it going to affect the quality of that person's life? And I love this quote because, again, I think we talked about this the other day. Nothing makes me more angry when I hear people say, well, you can't just give up. You just going to give up? That's not a fair thing to say to someone, because the truth is that, as we've learned, the death rate in America it's 100%. Yeah, we're all going to be there, and so that's not a battle somebody's going to win, right? So a lot of times we say things like, "Listen, I'm not asking you if you want to die. I'm asking you how you want to die, right? Because you are dying. That's not the question anymore. The question is how." And I love this because it says, even if a person who decides to forego treatment is not necessarily choosing death. You don't choose death. Nobody chooses that. That's what's happening. And just because you decide to change your battle, right? Your battle may be to be home with your kids, to be home with your dog. It's always the dog. I'll tell you a funny story in a minute. So when I was a baby nurse, I get very attached to my patients, which some people say is bad. I say if you don't get attached, you probably should find another job. But I got very attached to this guy, and I said to him, as I often say to my patients, what's one thing I can do for you? You want Chinese food? You want a slushie? Tell me what you want. And he said, I just want to see my dog. I love Tinkerbell. He's my buddy. I've had him 13 years. That was the goal, to see Tinkerbell. Okay, when I say Tinkerbell, what kind of dog does that think? It's a Chihuahua, right? It's probably a little yappy dog. So the next day, I told his wife, bring Tinkerbell to the hospital after 5 o'clock. Nobody important is here after 5 o'clock. We'll come up the back hallway. So I got to the bottom. It was funny, too, because I brought a duffel bag. I was going to put the dog in the duffel bag and sneak it up. And so when I got his wife was meeting me at the ER, and out gets a Great Dane. Yeah, I literally could have rode the dog in. But so I called my friends in security. I'm like, I'm going to need you to turn your head for just a few minutes. But the dog climbed up in the guy's bed, happy as that was what was most important to that guy. And he died 3 days later. And he never got to go home. Right? So for me, that is what my job is. That's what's important to me, is giving people that, last bit of, this is what means the most to me, and this is how I want to spend what time I have. I've got myself in lots of pickles. Yeah. So when do you opt for life-sustaining treatments? Things like chemotherapy, dialysis, surgeries, procedures. When is enough? And again, that's often determined by the patient, but sometimes the patient doesn't have a voice, and sometimes the patient can't tell us that. And so a lot of what my job is advocating for that patient. And like I said, I know PT says the church hasn't been really good at talking about death, but I think the medical community is worse. Because, we've all watched ER and things like that. What do people say about death on shows like that? Not on my watch, right? Not in my ER. Nobody dies today, which is silly. But I don't think we're any better at it, because we also view it as failure, right? If you died and I'm your nurse, I clearly did something wrong, right? It wasn't the terminal disease that you had. It was my fault. And so that's why we don't talk about it. So there's always one more test I can do, or one more chemo I can give you, or yes.
In the hospital, there's no money in dying.
There's a lot of truth to that. I'm trying to think if I should get up on my soapbox or not. You're right. I could fix Congress in like 2 days. I feel like. I feel like I could help. I could fix
Crystal for
healthcare.
president.
65% of Medicare dollars, which is what most people have as insurance once they reach a certain age, 65% of those dollars are spent in the last 6 months of life. That's crazy, right? Think if we put all of that resource treating obesity or diabetes, or something that we can maybe make a difference in. But we don't, right? We wait till the last 6 months of someone's life before we throw all that at them, and it's just nuts. It's nuts. I shouldn't say it that way. It's nuts from a medical perspective. I understand, when your loved one is sick, you want to try to do all these things, but if someone was upfront and honest with you about what that was actually going to provide your loved one, you might make some different decisions. But we're not good at that. We're just not. Some of us are. And then, so this is my favorite thing to do. When I go in and talk to a family, I will tell them, you know what, when the oncologist or when the kidney doctor comes in, ask him what he would do if it was his mom. That makes them very uncomfortable when you ask them that. But the truth is, that's how they should be treating you, like that was their mom. So I love that. And they've caught on, some of the doctors have caught on. They're like, don't tell them to ask me that. But that's usually one of the first things I say. If this were my mom, I don't think that I would do this, right? Because I think people need to hear that. They need to hear, this is the reality of things. And I'll pray with you for the best outcome, but I also need you to understand that this is what we see from a medical perspective. And then what does option A look like versus what option B looks like? So if I come to you and I say, hey, I can give you this treatment, it may make you live an extra 3 months, but you're probably going to be in the hospital and you're going to be vomiting and you won't be able to eat and, all these horrible, horrific things are going to happen. Is that still okay? Do you still want that treatment? And some people say yes. Yep. If it'll give me 3 more months, I'll live through it. I'll survive it, right? But some people are like, no, thanks. I don't want that for myself. I want to go home. I want to be with my dog. I don't want all that. But we don't say a lot of things like that. We usually give people much more fluffier information. And again, is it going to improve the quality or quantity or both of my life? We really have came a long way in lots of medical treatments. Sometimes we do make people feel better with treatment, and we make them live longer. But that's a good question that you need to ask. How is this going to affect the quantity and quality of my life? And we never give up. Never. There's no giving up, right? Sometimes we may change our battle, right? The battle may be to get you to that wedding or to get you home or something like that, but that's not giving up. That's reframing your hope, which is so important, right? And just think about what you're fighting for. I think that was in that video, that's kind of what he was saying, right? All this other stuff doesn't really matter. What matters is what matters most to you. If it's being home with your grandkids or whatever, is that what we're going to fight for? This is the big one. This is the one that people have the hardest time with, because what do we like to do here in Appalachia? More than we like to eat, we like to feed other people, or at least maybe women. Right, and if I love you, I feed you, right? We've all had that grandma, right? I did. Hello. I used to weigh 280 pounds. I definitely had that grandma. But it's how we show love to each other, right? If I feed you, I love you. We can't stand the thoughts of someone starving to death. I know PT mentioned his mother-in-law last week about the discussion of a feeding tube. It comes up all the time with patients and families. But the truth is that your body, God made you well, and your body is very smart, and it knows how to die. And not eating is part of that, right? So when your kidneys shut down, what do you not do? You don't make water. That's the Appalachian term. Yeah. You don't, if your kidneys don't work, you're not making water. It's the same. You're welcome. But that's what is supposed to happen when your kidneys don't work, right? Your gut works the same way. When you're dying, it's not hungry. It doesn't want to eat. And so when we shove feeding tubes in those people, oftentimes it can cause a lot of other issues to happen, right? Because your gut's like, hey, I don't want that. And so it can cause a lot of problems when you start to artificially feed someone. But this is hands down the hardest part of my job. People will take grandma off life support. they will take grandma off dialysis, but if you want to take that feeding tube out, it does not go well, usually. Again, very culturally, that's a very Appalachian thing. I have friends who have a nurse practitioner that I know that lives in Massachusetts, and she's like, I never have to talk to people about feeding tubes. Really? Like, I feel like that's probably 80% of my job is talking about feeding tubes. But I don't think that's popular everywhere. I think that's a very cultural, very Appalachian thing. Can you allow people to starve? I know you have thoughts on that, Shirley. Anybody? Anybody had experience here?
I said, how many days does it take for someone to starve?
Yeah. I mean, for them, you can go without food for a while, but water is a little more important. Usually we tell people if grandma's not eating or drinking, she certainly has less than 2 weeks life expectancy, and that's probably being a little bit generous. But that's another good sign. You know, when grandma stops eating, or if she's just eating, you know, not enough to keep a bird alive. It's another Appalachian term. You know, if grandma's not eating a whole lot. The other thing is, when your body starts to deteriorate, you can't swallow well, right? And so when that starts to happen, you oftentimes will swallow food into your lung. That's called aspiration. And incidentally, if we put a feeding tube in you, guess what? You're still going to aspirate, right? So we didn't help you with that problem at all. Now, don't get me wrong. There are times when feeding tubes are appropriate. If you have a problem we can fix, and then we can take that feeding tube out, great. If you weigh 72 pounds and you have a terminal diagnosis, that feeding tube is going to cause you more harm than good. Right. I mean,
Oh, for the most part, they don't know they're starving.
right. And so oftentimes what happens is once we shift gears, right? So once we say, you know what, we're not going to do anything aggressive anymore. We're going to focus more on making you comfortable. Then that's when, you know, if you want a Big Mac, we'll get you a Big Mac. If you aspirate, that's okay. Right? I say all the time, like, if I aspirate on tube feeding and that be what takes me out, I'm going to be really upset. Like, I want to aspirate on cheesecake if that's what's going to happen. But yes, you're right. When people are at end of life, they don't want to eat. They don't want to. Now, if they ask you for food, great, give them to it, or give them food. If they don't, then don't. You know, we can't. When you start forcing food on people, doesn't go well. Especially like dementia patients, people with Alzheimer's, things like that. That is a very natural progression of that disease. They don't want to eat. They'll chew it for 3 hours, but they'll never swallow it. Right? That's normal. That's okay. That's allowed. And so when we force things like that with artificial feeding tubes and things like that, it's not changing that person's outcome, right? So why put them through that if it's not going to change their outcome? Will this prolong life? There's about 9,000 studies that show no. If it's a true terminal diagnosis, then no. That feeding tube is not going to make them live any longer. As a matter of fact, it may actually shorten their life because they may aspirate and get a pneumonia or something.
Question.
Oh.
You bringing this stuff up about the feeding tube. I just wonder, I mean, do they inform patients about these possible side effects and consequences? Because I'm not sure in our case recently that we maybe had all this information before we made that decision. So.
Probably not. I mean, and I hate to talk bad about doctors because I really do have a bunch of them that I love, but what they hear is this is something else I can do to make this person live longer, right? So I'm gonna do that. But then you never really sit down and think about, and maybe that's the difference in a nurse and a doctor, because what I see when I see a little frail person that has a feeding tube, I'm thinking, oh no, either A, they're going to aspirate, B, they're going to get horrible diarrhea, probably also not been said from the pulpit, and then they're going to get a wound, and that's how my nurse brain works. But no, I don't think that we explain it in good detail.
You being familiar with end-of-life situations, maybe you have more
Yes, and
experience
also
and
I am
knowledge to explain it
comfortable talking
versus
about
somebody who
death.
didn't,
Yeah, which is
Well, and
not,
I think too, having this conversation, I mean, at least this group of people now knows if they're in that situation, let's ask about that feeding tube and whether it is going to help or not going to help. And,
Yeah.
And tie that with what Dow said, that it's not just about the hospital or wherever making money now. It's about dying well.
Yeah. Yeah, and that's, another good point. I mean, I've been in a ton of, we do this thing sometimes called family meetings where we get all the doctors together with the family. And I've been in so many of those where doctors will say things and I'm like, what are you talking about? Because doctors don't like to talk in absolutes, right? They're never going to say to you, we are 100% sure that your loved one is not going to come off this ventilator. They can't do that. They can't give you that guarantee. Now, I will say things like that, but that's the problem with medicine, is that there's always that outlier, right? Everybody knows somebody whose Sunday school teacher survived some horrific house incident, right? And so everybody thinks that way. Well, what if my loved one's this one person that's going to be the outlier? And so that's why doctors don't say things like, yes, we're 100% sure that, this person is going to pass away. They'll say things like it's very likely, or, other fluffy kind of words like that. So, and like I said, I've been talking about death now for a long time with patients. And so I think it is something that it's the elephant in the room that nobody likes to talk about. But like you said last week, you're missing so much opportunity if you just ignore it. Because it's going to come regardless of whether or not you talk about it, right? But I think that's the other issue. Oh. So this is just, what time is it? This is the other thing I just wanted to say, is that really no decision that you make is wrong, right? If you're making this decision for someone else, it's not going to be wrong, right? There's no right and wrong, because whatever decision you make is going to be made because you love that person. And so you're just doing the best you can with the information that you have, right? And so that's a lot of times where I come in, is to kind of sit down and talk with you about, realistic options and outcomes. But there's no right or wrong answer. If you put a feeding tube in someone and it doesn't go well, that doesn't mean you did something wrong. That's the best that you could do with the information that you had. Any questions on that?
Hello. Hi.
Hi.
Just a comment.
Yeah.
And our family has been through this. I went through it with both my grandparents, both my parents. And you said these decisions need to be made ahead of time.
Yes.
But even though those decisions are not made, it can be made and on paper, and this is what I want, and you have a medical power of attorney that's going to make sure that happens. Mm-hmm. But when you get to that point,
yes,
they still don't understand what that means.
Yeah.
Family doesn't understand. The person themselves may understand, but the family doesn't understand, just like my brother thinking we were starving her to death.
Yeah.
And in my mind, I am doing what I was told.
Yes.
This is what she wanted and this is what's going to happen, and I'm not going to do anything against her wishes.
Right.
So, that's just me and my brother having that conversation. Of course, Terry was there to help, kind of walk him through that. And once everything was done, he was fine, but he was struggling during that. Everyone's going to struggle watching them suffer.
Yeah.
But when you have several siblings, and Holly, I know, is going to come in and talk too, they don't know what hospice is. They think hospice just makes you die.
Yeah.
Yes. And, Holly even said one time they signed up for hospice, and she came in, and they came in, they said, you sit down on the couch, and if we need you, we'll come and get you. Holly said, I'll be right here. Because they don't understand, and like she's there to teach and help, like you're there to teach and help, but it's like, no, we're in charge here, you're not in charge here.
Yeah.
So much goes on, you really can't plan.
Were you your mom's medical power of attorney?
I was.
Okay, and why do you think she made you her medical power of attorney? Because she knew.
She knew.
Right?
Right. My brother is not the
Is your brother a baby?
Yes. Enough said.
You're a psychiatrist too?
No, because I actually brought some medical power of attorney papers to give out next week if you guys want to complete those. And I tell people, I say it jokingly, but there's some truth behind it. First of all, do not name someone your medical power of attorney who you know is going to be emotional and not be able to carry out your wishes. A.
Right.
B, if you have a baby boy.
Don't do it.
No. Bad. Mommies. For mommies. Baby boys can do daddies.
Yes.
Baby boys don't do well with mommies.
My baby brother could not do either.
Yeah.
And there's so many, and with Terry dealing with, with families.
Yeah.
I mean, there's some ugliness that happens.
Yes, always.
But in our family, my brother was, I was power of attorney. I was everything, over everything, finances, everything. And my brother was, you just take care of it and just send me a check. And, you don't get that.
Yeah.
You get so many battles and ugliness that creeps out. Our family was not that way, and I'm just so thankful for that.
Yeah.
Even years after Mom passed, I'd get a check in the mail. I could have kept it, but I'm like, hey, you're getting $1,500. He's like, well, thanks. Yeah. So it's I think they put the person in charge that they know is going to look out for everyone's best needs, not just theirs, but the entire family after they're gone.
Yeah. And we're going to talk about that actually next week, about living wills and medical power of attorneys and all those sorts of things. But
your nails are beautiful. Color straight. Go ahead.
But that's so important is, oftentimes the person that you make your medical power of attorney is the person you're closest to, but sometimes that's not always the best option because it's the person that you're closest to, right? Because we all get very emotional during that time, and sometimes things get muddy, and you just want to keep that person that you love, at all cost. But that's why you choose your medical power of attorney very strategically. Yeah, I always say I want an ICU nurse to be mine because they know how to get things done, right? They're just doing it, right? But yeah, Daniel actually, his parents made him medical power of attorney, and his mom told me, she pulled me aside, and she was like, we just made him medical power of attorney because we know you would be the one making the decision. So, yeah. It's okay. Yes, baby boy. Yes, baby boy. Does anybody have any questions? So I do in.
It's got to be on the tape.
How does family get to you?
Yeah. So most places have some sort of palliative care, supportive care, sometimes they call it. At Cabell, I see people who are in the hospital, but we also have a palliative care team that works in the cancer center. And they do lots of things. Don't think it's just, oh gosh, I'm going to see the palliative people. Clearly, I'm going to, die in the next week. They do a lot of stuff. They do pain management, symptom management. If you're struggling with your treatments, they can kind of help you tolerate those better. So that's how it works at Cabell. But most places, most places have that supportive care team.
I don't want to put you on the spot, but I know that over the last 3 or 4 or 5 years, whenever the grief counseling was needed, that I've always pointed people to Crystal. So I know that outside of what you do at Cabell Huntington, if somebody really
I'm kind
needed
of that girl, I feel like
you.
now, which is fine, because again, that's what I love. But
that was part of my question is, I mean, we live in Ashland, so we live in Kentucky, and maybe they have one at King's Daughters or Belfont, or.
They do both.
But what if we don't want them? What if we want you?
Well, you see me every Sunday.
I may not be able to see you if I'm in a bed in the hospital.
I'll come to you. I mean,
you
I
promise. Hello,
I feel
everybody.
like Terry
watch.
and I we're like tag teaming people now.
Okay.
We'll just travel
Just so
together.
you- all right.
I know PT actually said that one time. He's like, if I'm ever in the hospital, just don't come and see me.
How do you know when to ask for somebody in your kind of position
That's a good
to
question.
tell us or to tell the family what the next move should be? The reason I ask is, for example, my mom, dementia, constantly losing blood, getting transfusions. The doctor said, we want to do a colonoscopy. I said, no way, she can't do the prep. Then they said, we want to do an upper GI, run a tube down her throat. Is there any prep involved? No. My mom, dementia, they want to do this test to see, and she has always been, yes, do whatever test. So we did the test. The day after the test, she can't swallow. She's dead 6 days later.
Yeah.
When do I know to ask for that?
Yeah, that's a good question. And that happens a lot, unfortunately. What I see is if you have a loved one that you are seeing that, you're seeing that, oh, she's sleeping more, she's not eating as much, she's falling. If you see that kind of decline, then that's when, you need to say, like, what's our goal here? What's the goal? What are we going to do if we find something in this upper GI? Are we going to treat it? Because if not, I'm going to say something else that's never been said from the pulpit. Don't pick a booger if you don't have a tissue. Okay? I'm not going to go looking for something if I'm not going to fix it, right?
Wait a minute. You can't just flick it out the window?
Oh,
I mean,
boys
I'm going
are
for it.
gross. Boys are gross. I mean, because we see that all the time. Like, we'll get 92-year-old patients in, and they're like, there's a spot on her lung. And I'm like, why are you looking at her lung? She's not, I mean, you know what I mean? Like, what is, I think that's when you start asking the question, well, okay, let's say you find something with this upper GI. What's the treatment? Can she tolerate that? Is that something that we're going to be able to safely treat her? Because if not, what's the point in finding out? Right, exactly.
If there's something, we'll cauterize it. If there's something, we'll just cauterize it. We'll do it. We're in there.
Yeah.
And I thought,
Okay.
okay, that doesn't
Sure.
sound terrible. But
Yeah.
then, like I said, 24 hours later, she can't swallow.
Yeah, and sometimes there's never really a good answer because sometimes we don't know that things are going to happen. But anytime I hear we're going to give anesthesia to someone who's demented, that makes me nervous because oftentimes that exacerbates that dementia. But sometimes we do things not knowing what the outcome is going to be. And if they felt like, okay, this is a safe procedure, it's just an upper GI, maybe we can cauterize it. I can understand why that would have been an option, I guess. Okay, I'm done. What do I do? Just
I appreciate Crystal. This is just week 1 of 4 that we get to have her with us speaking. She is awesome at what she does, obviously, and I think this is step 1 in really answering the question of when do we talk or how do we talk to, is having this dialogue. And there's not another church in the world that you're going to hear make water, diarrhea, and don't pick a booger if you don't have a tissue. Stand with me. Thank you, Lord, for tonight. Thank you for Crystal Vance. Thank you for the gifting that you have given her, Lord, to deal with difficult circumstances and situations. I pray that as we continue the journey, that she will continue to speak into our lives things that will help us as we continue to talk about death and dying. I pray that when we leave this place in just a few moments, you keep us safe. God, we love you, we bless you, we praise you, for it's in Christ's name that we pray. Someone say amen. Amen. Shake someone's hand, hug someone's neck, bump someone's knuckle, tweak someone's cheek.